Hello, everyone. My name is Jim Douketis. I'm an internist and thrombosis physician at St. Joseph Healthcare, Hamilton, and McMaster University in Hamilton, Canada. And it's my pleasure and privilege to talk to you about cancer-associated thrombosis on behalf of the International Initiative on Thrombosis and Cancer and my other colleagues, Dr. Dominique Farge from Paris and Dr. Jean Connors from Boston. We'll be talking about prevention of venous thrombosis in patients with cancer, bridging the gap between knowledge and practice. The objectives of this session is to talk about patients who have cancer and how to prevent thrombosis in these patients. Why is this an important problem? And we're going to focus on two populations. The first is patients who are having surgery for cancer. So these are the surgical cancer patients. What is the evidence for extended duration thromboprophylaxis, typically with a low molecular heparin? For which patients should we be doing this for and for how long? And the second group is patients with medical cancer who have not had surgery, and are there groups among this category who should be receiving prophylaxis, and again, for how long? So how are we going to do this? Well, first of all, we're going to just provide a bit of a background that will set the stage and why this is an important issue in terms of preventing cancer thrombosis in patients with cancer who are having surgery or receiving medical treatment. We know, I think, very well that there is a strong link between thrombosis and cancer, but also that in patients with cancer as compared to those who do not have cancer, they're at fourfold higher risk of a first thrombosis, threefold higher risk of recurrent thrombosis, and also an increased risk for anticoagulant-related bleeding. So we need to be very careful about anticoagulant administration. And we also need to acknowledge that many cancer patients have compromised quality of life and that thrombosis will impact on their quality of life. You're familiar with the fact that the type of tumor has a bearing on the risk of thrombosis, as you can see in this slide, so that we're dealing with a very heterogeneous population, and often our recommendations will be specific to the type of cancer an underlying patient will have. We know that in patients having surgery for cancer, there's a wide variability in their risk for thrombosis after surgery, and that overall, the risk for symptomatic thrombosis is quite high in relative terms, between 3 and 4%, but that this risk varies widely depending on the type of surgery that they are having. And importantly, we need to address that in cancer patients who are having surgery, that the risk for thrombosis often is delayed. And about 1/3 of episodes of thrombosis will occur beyond the period of discharge, typically within the first 30 to 40 days after discharge. And this may also affect our management. Among patients who are having cancer surgery, so let's consider now who should get prophylaxis and for how long. And we'll review the summation of the evidence briefly, but also should we be identifying which patients with cancer surgery that require prophylaxis? I think we're all familiar with the Caprini score, which helps to stratify patients who are having any type of surgery according to their risk for postoperative venous thrombosis. Is this helpful among patients having cancer surgery? And some may argue, well, it doesn't really apply that much. Why is that? Because most patients that will have surgery for cancer are already at high risk. That is, they have a Caprini score of at least 5 points, and many of them, as typified by the characteristics in the box on the right, will have up to 10 points. So one can say that this is a helpful model, but many cancer patients, and the default actually should be in these cancer patients having surgery, is to consider prophylaxis as the default management option. Now, what about the evidence for extended duration prophylaxis after patients are having cancer surgery? This is a most recent meta-analysis that has compared the efficacy and safety of prophylaxis using low molecular weight heparin of 7 days, which one might consider standard duration, versus 30 days, which is considered extended duration prophylaxis after cancer surgery. And if we go down to the main results, we'll see that the effect of extended duration prophylaxis with a low molecular weight heparin is to reduce the risk of any episode of venous thromboembolism by 42%. This translates to an absolute risk reduction of 8%, or a number needed to treat to prevent a thromboembolic event of 12, which is quite small. Now, even if we use the benchmark of symptomatic venous thromboembolism, which in this case confers a even greater risk reduction, but lower absolute risk reduction, I think this is still compelling evidence, and we also have to acknowledge that we're not just trying to prevent symptomatic VTE events in cancer patients. Many of the events that we see are incidental or pre-symptomatic. So I think using both of these outcome measures is important to help convince us that extended duration prophylaxis is helpful and efficacious to reduce the thrombotic burden. The flip side is, what about bleeding? Well, it doesn't appear that bleeding really has an impact here, because most of the bleeding is front-loaded immediately after the surgery. So if we extend prophylaxis from 7 days to 30 days, it's not surprising that we see no effect, no added effect of bleeding. So really, everything sort of favors prophylaxis in high-risk patients having cancer surgery. Now, let's move on to patients who are in the non-cancer area. So these are medical patients typically who are receiving prophylaxis, and who should be the ones that we should consider for primary prophylaxis to prevent thrombotic events. Here, we do have a clinical prediction model that actually is quite helpful. This is called the CrCl score, and this has been validated prospectively in multiple populations, and has shown that if patients have a CrCl score of 3 or more, they are at high risk for venous thromboembolism based on one or more of these criteria. So you'll see that the CrCl score incorporates the type of tumor and other laboratory parameters, as well as patients' body mass index, to provide an estimate of risk for thrombosis at the time they've been diagnosed and are initiating therapy for their cancer. And again, these are medical, not surgical patients. Now, rather than looking at a meta-analysis, let's look at two very key studies briefly that inform how to manage these patients. The first study is the AVERT trial, which took patients with newly diagnosed cancer or cancer progression who had a CrCl score at least 2, and they were randomly allocated to a direct oral anticoagulant, apixaban 2.5 milligrams twice daily, or matching placebo, and they were followed up over a several-month period. Cutting right to the results, you'll see that the patients who received apixaban had a benefit in terms of reducing the incidence of venous thrombosis. If we look at the actual numbers, here you'll see that the administration of the anticoagulant resulted in about a 6% absolute risk reduction. Numbers needed to treat that correspond to this is 17. And once again, these combined symptomatic and incidental thrombotic events. On the flip side, what about safety? Well, there was some increase in major bleeding, as you can see here, but overall, this was outweighed by the efficacy of preventing thrombosis. So overall, this study suggests that we should be considering prophylaxis in medical patients starting on treatment. The second study that looked at a different drug, in this case rivaroxaban, took the same type of patient population, patients who had various solid tumors, medical cancers, who were initiated on treatment, once again with a CrCl score of at least 2. The only difference in this trial is that patients had baseline ultrasounds and repeat ultrasounds done to detect more actively the presence of new clots in the lower extremities. And what you'll see in terms of the results of this study, both for patients who were followed overall and among patients who were maintained on treatment, that there was a significant risk reduction in terms of thrombosis. In terms of the safety side, in this case, there was no significant increased risk for bleeding. So overall, taking these studies together, this supports the premise that we should be considering prophylaxis in medical patients with cancer who are starting on treatment, with the important caveat that we need to identify the risk category that they fall in, because we don't want to be administering prophylaxis in all patients, irrespective of their risk. And this is an important part. We've finished up the background. I've hopefully demonstrated to you now the importance of this clinical problem and the key populations that we want to focus on, which are patients having surgical cancer resections or medical patients initiating chemotherapy. Now, let's look at the ITAC clinical practice guideline and how we can take that evidence, look at what the guidelines tell us, and apply it to the bedside, to the clinic, or virtually these days in the assessment and management of our patients. This guideline, I think, is an important and unique because it takes the recommendations and places them in your hand in the form of a free downloadable app that's very user-friendly and meant to be used at the point of care to help in your decision-making about the treatment as well as the prevention of venous thromboembolism in patients with cancer. So we're going to go through a few cases now. Buckle up. We're going to be going pretty quickly to illustrate how to use this app in your everyday practice. Here's the first case involving a patient who is having a liver resection for an isolated hepatic metastasis following a colon resection that was diagnosed and treated 2 years ago. She's expected to be in hospital for 3 to 4 days after her liver resection surgery. So my question is, how long do you think this patient requires prophylaxis? 3 to 4 days in hospital only, 7, 14, or 28 days. If we go through the app, once again, it'll be a very simple process to identify the guideline that helps inform practice for this patient. In this particular case, the recommendation is a strong one, grade 1A, to administer extended duration prophylaxis with a low molecular weight heparin in this patient who is at high risk for thromboembolism, but she did well after her surgery and is considered at low risk for bleeding. Let's move on now to the next case, also a surgical patient, but a different scenario. Here is a 57-year-old woman who's scheduled to have a lumpectomy for breast cancer resection. She has no other health problems and has a CrCl score of 0 and is expected to receive post-operative adjuvant chemotherapy. So it's a bit of a mix here between surgical and medical management. So in this patient, what do you think about the need for prophylaxis? Either no prophylaxis, yes, 7 days, 14 days, or 28 days. Once again, the app will kind of guide you to the specific recommendation and to help manage your patient. What we're dealing with is really more a medical kind of management. Although this patient had surgery, it was a fairly limited surgery. It was day surgery, and now she's going into the outpatient kind of realm and is more in the medical management category. And in this patient here, the recommendation is not to routinely administer an anticoagulant because she's ambulatory. She is receiving systemic anti-cancer therapy, but her CrCl score is low, is only 0. So this is somebody that we would not routinely administer DVT prophylaxis to prevent thrombosis in this clinical setting. Let's move along now to a different patient. Here is a 69-year-old male who's scheduled for a lobectomy for lung cancer resection and is expected to have epidural analgesia post-op. And of course, that's going to influence part of our decision. And I think we put this part in because in each of these scenarios, we expect that there will be some sort of what we refer to as what if situations. And the guidelines will not address each and every one of these situations, but we have to sort of incorporate our clinical judgment in addition to what the guidelines tell us. So in this type of patient who is having a lobectomy, what do you think we need to do in terms of VTE prophylaxis? Only in hospital for 4 to 5 days. And if we do consider this, I can tell you that the administration of an epidural analgesic is not a absolute contraindication to co-administration of a heparin, typically a low molecular heparin. But that aside, do we think this person just needs in hospital 7 days, 14 days, or 28 days of prophylaxis? Now here, the guidelines are a little bit ambiguous. Why is that? Well, it's because we don't have a lot of specific data for patients who have undergone lung and esophageal cancer surgery. So in this case, one might extrapolate, if you will, and this is based on your own clinical judgment about perhaps administering extended duration prophylaxis in patients having major cancer surgery, but we don't have a specific recommendation in the guideline for this population and typified by this patient just because those data for lobectomy or esophageal resection are lacking. So you may want to consider extended duration prophylaxis, but with the caveat that it is sort of an extrapolation. And in this circumstances, certainly clinical judgment would be appropriate. And then you may even want to consider a shorter duration of prophylaxis in the absence of direct data. So the guideline is not the be all and end all. It helps you in terms of your management. And of course, it is coupled with clinical decision making. The fourth case is a patient now who is having cancer surgery for colon cancer, but not with open, but in this case with laparoscopic resection of the tumor and administration of an ileostomy. There are some comorbidities, and this is a type of surgery that we're seeing more and more of and is associated typically with an overnight stay. So does that influence your decision making? In this case, do you think that this person doesn't need any prophylaxis, or should we consider 7, 14, or 28 days? Once again, if we navigate through the app, very easy to do that. We'll see here that the recommendation is pertaining to cancer surgery with a laparoscopic approach. The recommendation is similar to that with if this patient had an open laparotomy. The only caveat, as you can see, is that this is a weaker recommendation, a grade 2 instead of a grade 1. Why? Because we just don't have that requisite data specifically for laparoscopic surgery. It's not as robust as it is for non-laparoscopic surgery. So there is evidence, not as strong. There's a recommendation for extended prophylaxis, but nobody would fault you for saying, you know what, I'm going to use a shorter period of prophylaxis, particularly lobectomy if this patient is otherwise healthy or ambulatory. So there is some flexibility here in terms of the potential answers, and that this is not a strong recommendation for 4 weeks. It's a suggestion more for 4 weeks of prophylaxis. Let's move on now to the next case. Here is a 58-year-old woman who has invasive breast cancer. I'm not going to go through the details of all the different markers that she is manifesting, and is going to be started on chemotherapy, fairly heavy duty, and you can see a number of her clinical characteristics as well as her laboratory findings. Based on this information that I've given you, what should we be doing? Should she be receiving prophylaxis to prevent thrombosis while she is initiated on chemotherapy? Maybe not. Maybe we can give her aspirin or a low dose, low molecular weight heparin, or even a low dose direct oral anticoagulant. Once again, easy to navigate through the point of care app, which I want to just stress is really a unique feature among the ITAC guidelines. And I also would stress, as my colleagues will, that it's available in multiple languages, including English, French, Spanish, Portuguese, and Russian. The recommendation is that this patient should not receive prophylaxis, which might seem a little bit counterintuitive. You know, she's receiving heavy-duty chemotherapy, but once again, the decision is anchored on the CrCl score. And if you actually look at her clinical and laboratory characteristics, in fact, her CrCl score comes out to 0. So, of course, there is some clinical judgment involved, but in general, this is not a type of patient that we want to routinely administer thromboprophylaxis. Our next case involves a patient with newly diagnosed lung cancer, small cell cancer with an isolated brain metastasis. And this person is going to be starting chemotherapy. Their CrCl score is 1. The question is, should he be receiving prophylaxis, yes or no? Once again, navigating through the app will guide us in this regard. We will see that pharmacologic prophylaxis is not routinely recommended in patients with locally advanced or metastatic lung cancer, as this patient has, who is starting systemic chemotherapy, and that these type of patients would be considered for clinical trials of antithrombotic prophylaxis. So this is a population that we are not routinely administering prophylaxis. Here's a patient who had a stomach cancer surgery resected a couple of years ago, a 68-year-old man, and now has clinical radiologic evidence of intra-abdominal recurrence and is going to start chemotherapy. His CrCl score is 3 based on the cancer type. He also has an elevated white cell count and has a BMI, body mass index, over 25. Should he be receiving prophylaxis, yes or no? Once again, go through the app, several easy to navigate steps. And what we'll get is this answer is that, yes, this is a person in whom thromboprophylaxis with a direct oral anticoagulant is recommended. This is based on their CrCl score. And I just want to highlight a small caveat that despite this person having gastric cancer, we have found in the TRUE trials, the AVERT, and the CASSINI trials that when thromboprophylaxis is administered, despite there being a gastrointestinal cancer, there does not appear to be an increased risk for bleeding, as we've seen when the DOACs are administered at therapeutic doses. So this is a very different paradigm in case you're kind of wondering about that. But once again, this is a patient in whom we would be considering routine administration of a DOAC for thromboprophylaxis against thrombosis based on the CrCl score of at least 2 or more. With all patients who have cancer and thrombosis, there are myriad of what-if scenarios that we can encounter, and we can't really go through each and every one of them, but suffice it to say, we probably will encounter at least one or more of these, which include thrombocytopenia, patients with severe renal insufficiency, extremes of weight, potential drug interaction, and brain metastases. The ITAC guidelines take things a step further, if you will, in that not only do they provide guideline-based recommendations that are anchored on well-designed randomized trials and other studies, but we also provide guidance for these type of scenarios.